Alrighty, and so apologies to those who weren't able to be in class last week. We were still having Zoom problems. This week I finally just figured out I can bring my laptop. That's a lot better than trying to get this thing to work, unfortunately. But we just basically covered the first few slides, and I'm glad to answer any questions about those. But what we've gotten up to is anxiety disorders. And these are things we can see in people of all ages. In particular, these tend to be more diagnosed in adults, but certainly we can see them in kiddos, since I know a lot of y'all are working with kiddos as well. Alrighty, let me do this. Turn on these captions. So generalized anxiety disorder is actually the most commonly diagnosed anxiety disorder, which is ironic because it's the one that like the general public knows the least about. And I think that's largely because it can be hard to portray in like an entertaining way, right? In movies or things like that. OCD, you can sort of make a stereotype of it, right? Phobias, you can kind of make a stereotype of it. GAD is a little harder to depict. So generalized anxiety disorder is excessive anxiety under most circumstances. They worry about everything. I've always been a worrier. The symptoms include restlessness, fatigue, difficulty concentrating, muscle tension from just like being on edge all the time, and or sleep problems. So that includes like trouble falling asleep, waking up in the middle of the night and having a hard time getting back to sleep, or what they call early morning waking, when you wake up maybe an hour or two before your alarm and can't get back to sleep. In order to be diagnosed, your symptoms have to last at least 6 months. The reason they put this on there is to make sure we're not just diagnosing people who might be going through like a month of really stressful times, right? As I mentioned, it's really common. It often first appears in childhood or adolescence. And only about a quarter of people with this disorder are currently in treatment. So a lot of people do not seek care for this because they just sort of assume this is normative in some way. Specific phobias, again, easier to portray in media, so folks are more aware of these. These are things like arachnophobia, right? Fear of spiders, or fear of heights, fear of blood or injection injury, things like that. And so you have to have a marked, persistent, and disproportionate fear of a specific object or situation. So for example, if you lived in Australia in the outback and you had a fear of snakes, that would not be disproportionate. There are like, I don't know how many species, pretty much every species of snake in Australia can kill you, right? But if you live in New York City and you have a huge fear of snakes, right? Probably going to be disproportionate unless you like know someone who has snakes all over their apartment. Basically, when you're exposed to the object or the situation that you're fearful of, it's immediate anxiety, sometimes verging on like symptoms of panic. And they will do all kinds of things to avoid the feared situation. And that's going to lead to significant distress or impairment in their lives. Agoraphobia literally translates to fear of the marketplace. And it's fear of being in public places or situations where it might be hard to escape should you become incapacitated in some way. So they have this marked disproportionate and immediate fear of like public transportation, open spaces, stores, theaters, crowds, or sometimes it gets so bad that like these folks do not leave their house. They're sort of really confined. A fear of these situations is, as I just mentioned, related to the concern that like they couldn't escape or they couldn't get help if they needed it. So some of these folks will have panic as well, panic attacks, and they're afraid they'll have a panic attack in public and people will stare or they won't be able to get help. But some of these folks have physiological conditions. So like they might have epilepsy and have a fear of having a seizure in public and not be able to get help. Or ulcerative colitis or Crohn's disease or IBS, any number of things that can lead to like needing a toilet really quickly, right? So they'll avoid those situations, and that makes their world smaller and smaller. And again, 6 or more months typically, and distress or impairment. And the one thing that's really interesting about this one is it typically develops a lot later than these types of anxiety disorders develop. This would be like in your 20s or your 30s, typically after people have developed the other conditions. Social anxiety disorder is used to just be called social phobia. They changed the name to make it, I think, less stigmatizing. So these are marked, disproportionate, and persistent fears or anxiety about social situations, particularly if they feel like they're going to be scrutinized by other people. And again, 6 months or more. It may be really narrow. So the most common narrow version of this is fear of speaking in public. So for folks who have that, they can be given like a fast-acting anxiolytic, or there are behavioral things you can do with them to help relieve their anxiety before they have to give a speech. It could just be more broad, like a general fear of just having to be around other people, even like at a party or something. And these people think they're not as good at being social as they actually are. Like they rate themselves very unfavorably. But if you talk to someone else who had just had a conversation with them, they might not even realize this person is socially anxious. So they have this fear of being negatively evaluated by other people, or of being offensive to other people. And then basically anytime they're in that social situation, they experience the anxiety. And again, they'll avoid it, which, you know, depending on what your school or your job is, right, could be really problematic. Like if you have to give class presentations, or part of your job at work is to schmooze people or to give presentations as part of your job. And then distress or impairment, obviously. All right, and then panic attacks. Now, one of the things I always lay out when I talk about panic attacks is that most adults have had a panic attack in their life. That does not mean, like, not necessarily people your age, but like by the time you get to be like, let's say your parents' age. That does not mean you have panic disorder. Panic disorder is like recurrent panic attacks. So it's a very fast surge in intense fear or discomfort. It peaks within minutes and is typically done within 10 minutes. And you have to have 4 or more of the following. A lot of people who have panic attacks kind of have all of these. So your heart pounds, you'll sweat, you'll shake, you'll have shortness of breath, you have a sensation that you're choking, or chest pain, nausea, feeling really dizzy, temperature extremes, yeah.
You said it. Something about it being 10 minutes. What would you call it if you were to have these symptoms for like 2 hours?
Good question. Yeah, it could still be a panic attack. Sometimes they just don't resolve.
Okay.
Yeah, that's a really good question. Basically what happens here is that your body is in fight or flight mode when it doesn't need to be. So all these are a symptom of like preparing to either fight somebody off or hike it out of there. And so if your body stays in that state, doesn't feel like that threat is gone, there are people who can feel this way for hours. Yeah. In fact, like a lot of people will go to the ER when they have a panic attack because they think they're having a heart attack. And it's a good thing to do, right? Because if you have chest pain, you should just go to ER. Like just do it, right? And if it's just a panic attack, that's okay, right? But it can take people a while to get diagnosed because of that. Yeah, really good question. Paresthesias are like feeling loss of sensation in your extremities. Derealization is feeling like you're not connected to the world. Depersonalization is feeling like you're not connected or somehow like outside yourself. These folks will feel like they're losing control or going crazy, or sometimes they feel like they're dying. And again, all of these are just your body preparing itself. So like heart pounding, getting blood around, right? Shortness of breath, trying to take in more air. Nausea is because your digestion actually stops when you're in fight or flight mode, because your body is like, let's divert energy elsewhere. Dizziness is my favorite, because it shows the beauty of the human body. Blood is actually diverted away from your brain when you're in flight or fight mode, because your body doesn't want you to overthink it. So that's why people get dizzy. Because it's not that they don't have any blood, but they certainly have a lower blood flow than they're typically used to. So panic disorder, like I said, is where you recurrently have panic attacks. And they're periodic, often short. They fear they'll die or go crazy. And again, the absence of a real threat. If you're having those symptoms and there's a real threat, that's not a panic attack, right? That's your body just protecting you. So you have to have it for at least a month. And then what happens with people who develop panic disorder is they're constantly worried they're going to have another attack. And sometimes the internal symptoms that you experience from worrying can trigger another panic attack, right? So it almost becomes like a self-fulfilling prophecy. And you'll see them engage in all kinds of like avoidance or even like sort of superstitious behavior to try to avoid having another attack. Now, OCD used to be classified as an anxiety disorder. The DSM-5 gave it its own category, but there are certainly components of anxiety to it. So not surprisingly, it's made up of obsessions and compulsions. Obsessions are thoughts, ideas, impulses, images that feel like they're kind of like from outside you. You're not hearing voices, but you just like don't understand where these obsessions come from. And then the compulsions are the things you do to essentially try to quiet down the obsessions and the anxiety related to them. So they're repetitive and rigid behaviors or mental acts that people feel like, I have to do this or something bad will happen. And the typical one people think of is washing your hands. That can be like checking that you turn the stove off. It can be mental counting, all number of things. And so you have to have one or the other. Typically people with OCD have both. Because even if your compulsions are mental, right, they're still compulsions. And these become very time consuming. There are folks with OCD that like their compulsions can take up 6 hours of their day. It's really overwhelming. And then when the symptoms feel excessive or unreasonable, they're causing distress, they're interfering with daily functioning, that's when someone's given a diagnosis. And the good news is we have really effective therapies for this now, as we do for most of the anxiety disorders. Then there are the things called the stress disorders. So the one that most people know of in this category is PTSD. Again, these are now like their own category, but there's so much anxiety as part of PTSD that it used to be classified there. Acute stress disorder is not as well known, but it's basically the short form of PTSD, where your symptoms begin within 4 weeks of the trauma, the traumatic event, and then they last for less than a month. Now, some people will be diagnosed with ASD, and then, it'll last longer than a month, and then their diagnosis is changed to PTSD. PTSD, the symptoms can begin at any time following the event. So, for example, when I was at the VA in 2009, 2010, there were people who were coming in for the first time to address their symptoms of trauma from the Vietnam War. So from the late 60s, early 70s. And unfortunately, a lot of these people had not been experiencing symptoms because they'd been self-medicating. Like they'd essentially become functional alcoholics or other things along those lines. And then when they stopped abusing the substance, their symptoms came up. And the symptoms last longer than a month. They can start as quickly as ASD, but they don't have to. Wow, that turned out really tiny on these slides. I'll read it out to y'all. And so PTSD in particular is sort of like a They used to call it like a Chinese menu syndrome where you pick like some from here, some from there. I would say it's more like dim sum, right? Like the cart rolls by and you're like, oh, I'll take one of those and one of those. So like people with PTSD or things like schizophrenia can look very different with the same diagnosis, just depending on the constellation of their symptoms. So the number one thing is you have to have exposure to some sort of traumatic event. Actual or threatened death, serious injury, or sexual violation. So to you or someone else that you witnessed. One of the things I liked that they added to DSM-5 is that if it is part of your job to watch these things through screens, that counts. So for example, I had a naval officer that I treated while I was on my residency, that his job was to sit in a tent all day, every day in Iraq and watch everybody's helmet cams. So he was watching like people invading houses, marketplace explosions. And at that time, because he wasn't there, like we diagnosed him with PTSD, but it was like a little tenuous. And I think they must have realized stuff like that comes up now because they changed it. I finished working at the VA in 2010. The DSM-5 came out in 2013. And then you've got to have at least one intrusive symptom. So memories that pop up, distressing dreams, nightmares, dissociative reactions are the most common ones people think of. So flashbacks are where you actually feel like you're back in the moment. So for example, for Vietnam era vets, it's often if they hear a car backfire, it sounds like a gun, they hit the deck. Iraq, Afghanistan vets will be driving and something will remind them of like trying to avoid IEDs. And then they're driving down the middle of the road, like straddling the yellow line, because that's how they drove then. People who have had sexual trauma will be having consensual sex with someone they love and they'll get a flashback and feel like they're being assaulted again. So those are very difficult. Distress at exposure to anything that reminds you of the event. I had a person who had left the military but still worked for them civil service. That happens a lot to folks who get out of the military. That's where the jobs are. And he would leave the room anytime anyone talked about Iraq, which like he was working for the army. So they talked about it a lot. So it was really interfering with his job. And then physiological reactions that can be like panic symptoms to reminders of the event. They'll avoid stuff that reminds them of the event because of this distress. They'll have changes in their thoughts and their moods, like inability to remember important aspects of the event. There's some neuropsychological research to suggest this is actually your body trying to protect you, essentially your brain trying to protect you from remembering it. Exaggerated negative beliefs about oneself and the world around you, and then persistent negative emotions. So it could kind of look like depression at times. And then changes in arousal and reactivity. Hypervigilance is just always being on your guard. So if anyone has known someone who is either current or former military or law enforcement, and when you go into a restaurant, they sit in the chair in the corner so they can see everybody. That's a little element of hypervigilance. Exaggerated startle response is if someone does sneak up on them, they will jump a mile. This can happen if you wake up someone with PTSD. So a friend of mine an internship had a case where the guy's kid woke him up. He didn't know where he was. He thought it was like an enemy combatant, so he grabbed his kid by the throat. He didn't hurt his kid. It was okay, but obviously the kid was scared, and they had to be like, okay, we're not going to wake dad up when he's sleeping. Sleep disturbances can fit in here as well. And then distress or impairment, and that longer than a month. So PTSD is something that for a long time we thought could only happen to veterans or people who had been part of combat. And now we know it can happen from a whole host of different traumas. And in particular, things we don't even necessarily think about, like motor vehicle accidents, right? Sexual assaults. If you've been part of like an armed robbery victim, things along those lines, that can all lead to PTSD. And then big events, right? Like 9/11, there were increased rates of PTSD for people who just like lived in the New York area because they had to witness essentially the deaths of thousands without necessarily comprehending what was happening. All right, then we have the neurocognitive disorders. So these are brain-based symptoms, and they can be caused by a lot of different pathologies. And right now we have these separated into major versus mild symptoms. Mild is like there's modest decline, but it's not interfering with your ability to work or live alone. Major is substantial decline, and again, in one of these areas like memory, attention, language ability, social awareness, and like oftentimes these people have no pretense of living alone. You get someone in the later stages of a major neurocognitive disorder, and often they can't even like go to the bathroom without assistance. So there is this controversy in psychology in general and neurology as to whether we might over pathologize sort of the fact that like everybody experiences some neurocognitive decline as you age. It just happens to your brain. And so people worry a lot about this mild neurocognitive disorder. A diagnosis of it may be over pathologizing people. Like most people who are older are going to have some forgetfulness or word finding. And so we know that like neurologists, neuropsychologists are not going to overdiagnose this, but like technically your PCP could diagnose you with it, your primary care physician, right? And so there's a little concern about, are we going to diagnose people who just have normal decline as having a disorder? The most common neurocognitive disorder is Alzheimer's disease. Alzheimer's disease is awful and insidious and slow. It can be really hard to tell when someone starts because it does just sort of look like normal forgetting at first. And typically it's like an 8 to 10 year process from when you're diagnosed to when you pass away, but it can be longer. So it's essentially your brain declines so much when you have Alzheimer's disease that it shuts down, but that's a very slow process. And then memory impairment is the early and prominent feature here, but then you have to rule out everything else that could be going on with this person too, right? Delirium is one that we see in older adults, although we can see it in other ages as well. But it's where your awareness of the environment is less clear, you have difficulty focusing, and you could have hallucinations as a result. You can have just not understanding what's going on around you. And it comes on really quickly, and it's a very acute change. But if the person, let's say, is brought to the ER and they're not able to articulate their story, and the person bringing them in doesn't know their medical history, this can look like a major neurocognitive disorder, right? And so like, if people don't do proper screening, someone might get diagnosed with like an Alzheimer's type disease, but in fact, they're just experienced delirium. Delirium is often caused by acute medical symptoms. So things like a really high fever. It's very typical in older adults if you have a urinary tract infection. That's the most common one. So if the doctors are able to figure that out, you treat it with an antibiotic, the delirium goes away. But you have to like screen for that, right? There are other ones as well. Vascular is where it's related to strokes. And so it could be you have one big stroke and you have cognitive changes, or it could be a bunch of mini strokes that are called TIAs. It's progressive, but rather than Alzheimer's, which is like a gradual decline, it's sort of like you're doing fine, and then you have a cerebrovascular event, boop, your decline goes down. And then it's what is affected is very much dependent on where in your brain the stroke is, right? So if you have it over here, your language might be affected. You have it up here, your executive functioning might be affected. There are other things, frontotemporal neurocognitive disorder, also called Pick's disease. It's similar to Alzheimer's disease, but just has a different pathology, what causes it. Prion disease is a slow-acting virus that causes these symptoms. Huntington's is a progressive disease that's genetic. You have a lot of movement issues with Huntington's. Parkinson's is what Michael J. Fox has. He's sort of the face of Parkinson's disease now. And it's a slow progressive neurological disorder. You've got a lot of tremors related, and as you progress, you can develop dementia as well. We know that there are anger issues in older adults. And they can come from a whole bunch of different things. You know, people's personalities can change after dementia or a stroke. Sometimes they're just bored. Sometimes they have communication issues. And so focusing on the issues, trying to communicate with them. This is in here because in the past we've had folks at Our Lady of Perpetual Help, which is a assisted care facility. And there's a whole wing there that's for patients with dementia, and they've struggled with this. And that facility does a really good job of like increasing activity level and things like that. All right, TBI. I know a couple of you are working in TBI places. Nora's not here, but hopefully you'll get to watch it later. It's caused by some sort of injury to the head or body, but typically the head has to be affected. Bump, blow, jolt. One thing that people don't necessarily think about is things like blast injuries. So traumatic brain injuries, particularly mild traumatic brain injuries, which is another word for concussions, are considered the signature injury of Iraq and Afghanistan from the early 2000s because of the concussive blasts of the IEDs. So even if you don't even like fall over from the blast, your brain is sort of like jello inside your skull. And if a concussive blast moves through you, your brain is going to kind of go like this inside your skull and thus can get injured without you necessarily realizing it. You can have penetrating or open brain injuries where you have something like a bullet, shrapnel, or a knife enter your brain tissue. Key example here is Gabby Giffords, the congresswoman who was shot through the head and survived. You know, the bullet went through her left side of her brain, and that's why she has language issues. What we see more often, though, are the closed head or non-penetrating issues. So there's some sort of external force that's strong enough to move that brain around within the skull. If you fall, right? Some sort of car accident where you hit your head on, let's say, the steering wheel or the windshield. Sports injuries. This has been a talk for years and years, right? About like the NFL, things along those lines. But it can also be, they're trying to find more in soccer players from headers and other contact sports as well. Blast injuries, as I just mentioned, or just being struck by an object that's falling, something along those lines. And as I mentioned, MTBI or mild TBI is often someone has a concussion. And one thing that was really interesting when I was at the VA is they were really starting to sort out, like, how do we diagnose a concussion when it happened to someone months or maybe even a year ago, right? And so like one of the things they looked for was loss of consciousness, but that doesn't always happen with a concussion. So we started more looking at like, what are your symptoms now? A lot of these guys would get migraines, tinnitus, which is like ringing in the ears. My mom has this, not because of this, but because she used to go to a lot of rock concerts, stand in front of the speakers. And she said sometimes it's like a hamster wheel just squeaking in your ear the whole time, if you could imagine. Just like trying to get stuff done with that. A lot of them would have memory and attention issues as well. And then a lot of them end up with like ruptured eardrums and other types of injuries as a result of whatever caused the injury. Whoa, this is also really small. geez, I need to work on my PowerPoint skills here, but I can kind of read these to you. These are some of the signs and symptoms. Physical, you'll see headaches, depending on the person and the injury. Sometimes you'll see convulsions or seizures, blurred or double visions. Their pupils will dilate strangely. They'll have fluids draining from where they're normally not supposed to be. Nausea and vomiting, particularly right afterwards. And then sometimes they'll develop physiological issues in their limbs, balance, or their speech. Again, if they have that loss of consciousness, that's a pretty good indication it was a TBI, but sometimes it's just a decreased level of consciousness. They'll have confusion, disorientation, not knowing where they are, problems remembering, concentrating, making decisions. They'll have changes to their sleep patterns, a lot of like personality changes due to frustration related to the changes and everything else. They'll feel lightheaded. So a lot of them experience vertigo or blurred vision. I mentioned hearing problems. Sometimes they'll get like a metallic taste in their mouth. Be really sensitive to light or sound, especially related to migraines. Mood changes or mood swings. They'll feel anxious or depressed. And again, lack of energy, lack of motivation. So we see a couple different things that can happen. One is a minimally conscious state where there's some evidence of self-awareness or awareness. And these are like typically right after the brain injury, I should clarify. Vegetative state, whereas when they're unconscious but have no awareness of their surrounding. Sometimes they'll have alertness. If it lasts more than a couple weeks, they call it a persistent vegetative state. So if you've ever heard that terminology, that's what that means. Sometimes the injury is so bad they'll end up in a coma where they're unconscious, unaware, and they won't even respond to like pain or light. Sometimes they will induce a coma medically if the brain injury is so severe that they feel like the person just needs to rest. So for example, with Gabby Giffords, her brain swelled, not surprisingly, after like a bullet went through it. And they actually had to remove part of her skull to give it room to swell. And they put her in a medically induced coma for several days to just like give her body time to rest. And then what can happen sometimes is that you can experience brain death. So where like the body might still be functioning, but like you're never going to get consciousness back. And that's really hard for families. Types of injuries, and the injuries are typically caused by what happens to the brain when the blow or the blast happens. So diffuse axonal injury refers to widespread damage throughout the brain, throughout those axons. So what happens if your brain is like, again, if we think of it as like jello and it's bouncing around, it can kind of like turn those axons, that white matter can kind of go, that's not good, right? Or they could stretch and sort of start tearing. That's not good. Sometimes you'll get a hematoma, which is a bleeding on the brain, but from a rupture to a blood vessel. You can have a contusion, which is swelling or bruising on the brain. And then sometimes your skull itself will actually fracture. So just like any other broken bone, you need to attend to that as well. One of the things that we see more recently, particularly among athletes who get repeated concussions, repeated mild TBIs, is chronic traumatic encephalopathy, or CTE. So it's caused by these repeated hits to the head. The sad thing about CTE is you can only definitively diagnose it right now after death. Like our brain scan technology is not good enough to diagnose it without an autopsy, essentially. But then once you do an autopsy, it is very obvious. So here you have a normal brain, what probably everyone in here would vaguely look like. And then this is someone who died with advanced CTE. You can see a reduction in brain volume, increase in size of those vesicles and fissures in the brain. Very problematic. Symptoms of CTE, they have impulse control issues, aggression, mood swings, sometimes depression, paranoia, anxiety, thoughts of suicide, and unfortunately, a decent number of older retired NFL players have died by suicide. And what's unfortunately become a thing they do is they will shoot themselves in the chest and leave a note saying, please analyze my brain to see if this was CTE, which is really sad that like they're having to do that to get attention to it. You know, did Aaron Rodgers have CTE and that's part of what caused him to do what he did? Maybe, right? Lots of other things like that. Most patients with CTE have problems with thinking, memory. Executive function is like sequencing and organizing stuff. Judgment's impaired. Short-term memory issues. They'll develop symptoms of dementia. I believe there's now like a major neurocognitive disorder due to CTE in the DSM, and confusion. They think that sleep problems are very related here. But it's hard to parse that out apart from people who just have sleep apnea, which if you're not familiar with sleep apnea, it is a respiratory disease where you stop breathing for very brief parts of time while you're sleeping, but you do it repeatedly. And so anytime you stop breathing, the oxygen is cut off to your whole body, but including your brain, which is more profoundly affected by it. So over time, if you don't get your sleep apnea treated, not only does it cause non-restful sleep, but you can actually build up neurocognitive deficits as a result of this anoxia, lack of oxygen, several times throughout the night. So it might be sort of a combo of both for people with CTE. The most common causes of CTE, again, contact sports. There was one point where they called it something like boxer's dementia or something like that. But then they figured out that, you know, like American football is really the issue. But we also can see it in martial arts or rugby. People who have had multiple blast injuries or other injuries in the military. And then one that people don't think of is domestic violence survivors. If you've been repeatedly abused by being attacked around the head, right, you can get CTE from that. Alrighty, so next we're going to talk about psychosis. Alrighty, so psychosis is a state of being profoundly out of touch with reality. And one important thing to note about psychosis is if someone has psychosis, it's like saying someone has a fever. It's a symptom, it's not necessarily a diagnosis, right? So if someone came into their doctor with a fever, the doctor might test for strep throat, COVID, right, flu, a whole host of things. If someone comes in with psychosis, same thing. We're going to say, is it schizophrenia? Is it substance induced? Are they just tripping, right? Is it due to some sort of dementia, right? What's going on here? So the main two symptoms here are hallucinations and delusions. Hallucinations are in your senses, experiencing something that's not there. So seeing, hearing, smelling, touching, tasting things that are not there. Delusions are fixed false beliefs. So you're going to believe something that's just not true. And these can be that there's a vast conspiracy from the CIA and they're out to get you. These can be that you personally are Napoleon Bonaparte come back to life, right? Things along those lines. And again, as I mentioned, psychosis is this broad term, but schizophrenia is a type of psychosis that also has disturbed thought, language, and behavior. And in particular, those three things, thought, language, and behavior, tend to be disorganized as compared to a normal person in someone with psychosis. So when we think about schizophrenia, we think about two categories of symptoms. And I think people generally think of the positive symptoms when they think about this. So the positive symptoms here, or the type 1 symptoms, are the delusions, the hallucinations. They're pathological excesses, things that people who don't have schizophrenia do not experience. They're added on. This can also include things like those disorganized speech and behavioral things. The negative symptoms can be just as, if not more, debilitating. And these represent pathological deficits, things that someone without schizophrenia would have, but the person that has schizophrenia is lacking. So these can be things like lack of affect. So these people won't show that they're happy or mad or sad. It'll just sort of be flat. Or they'll have what we call inappropriate affect, laughing when they find out someone close to them has passed away. Loss of motivation. Some people will even just stop talking, have a lack of speech. And so these are the diagnostic, there we go, criteria for schizophrenia. So it has to be at least a month that they display these symptoms. The delusions, the hallucination, disorganized speech, disorganized motor behavior, and negative symptoms. And so you can see, you only need 2 of these categories, right? So you can have people with schizophrenia who have very different symptom constellations, but are diagnosed with the same thing. There was a study that came out, I don't remember how long ago. I always feel like I say sometime between 8 and 10 years ago for everything. So let's go with that. But there was a study that came out in the 2010s that showed that genetically, schizophrenia might be anywhere from 6 to 8 distinct different disorders. But right now, diagnostically, we still lump all of these together. But so you can see, you might have someone who has like disorganized speech and negative symptoms, right? And those are their symptoms of schizophrenia. That's going to look really different than someone who has the more psychotic symptoms, right? And so people with schizophrenia can present in very different ways. I have only ever treated one person with schizophrenia, and she was somewhat in remission. She mostly had negative symptoms, but she had paranoid schizophrenia, which is a subtype where it really focuses on the delusions and maybe related hallucinations. So she had been dating a man from Russia, and it was unclear to everybody whether or not he was actually part of the Russian mob or not, but she believed he was. And she was a teacher, and she was at school, and she had her psychotic break, and she believed there were helicopters circling the school coming to get her because she was dating this man. And after that, she, went into treatment. She was put on very heavy antipsychotics, so her psychotic symptoms were controlled. But some of these medications make you gain weight, and she gained about 80 pounds, and was having a lot of issues around her body and eating. She had a history of bulimia, so that didn't help, right? So I actually got her for that reason. But it was really interesting. I remember talking to my supervisor about her because I was just sort of treating her at that point as like a depression and disordered eating case. And I'm like, oh, I feel like I'm not helping that much. And he said, this is a really tough case. And it helped put perspectives back on things, right? That she had this underlying psychosis, and that did complicate the case. So they have to have A, B, or C in order for it to be schizophrenia. And they function poorly in life spheres than was the case prior to the symptoms. Again, using my client as an example, she had been working, living alone, and afterwards she had to move back in with her parents and could no longer work. Her parents would actually drive her to her appointments because at that point she was not confident enough to drive herself. And then they have to have at least some degree of impaired functioning for at least 6 months total, essentially. Schizoaffective disorder is if they have symptoms of a mood episode, either a depressive episode or a manic episode, at the same time as the primary symptoms of schizophrenia. That they come on at the same time, essentially. So they have delusions or hallucinations for at least 2 weeks when not experiencing those. Otherwise, there can be major depressive or manic symptoms present most of the time during these symptoms. It is possible to not be diagnosed with schizophrenia, but sometimes experience hallucinations during your mood episode. So I had a client who was bipolar, and during her depressive episode, she'd hear voices telling her to harm herself. She recognized they were outside of her and she would not act on them. But this would be when those symptoms are just really enmeshed, and every time you're experiencing mood symptoms, you're also experiencing these. Brief psychotic disorder is essentially 1 month and then it goes away. So you're having delusions, hallucinations, disorganized speech, disorganized behavior, for at least a month. But then you'll go back to your level of functioning. Sorry, from 1 day to 1 month, under a month, excuse me. Schizophreniform disorder is sort of the one between brief psychotic disorder and schizophrenia. It's your 1 to 6 month with these symptoms. And then once you hit the 6-month mark, that's when you'd be diagnosed with schizophrenia. Kind of similar to acute stress disorder versus PTSD. Delusional disorder is when you only experience delusions. Your functioning is only mildly impaired. Your behavior is only minimally odd or bizarre. You're not experiencing hallucinations as well. There's all kinds of different thought disorder or disorganized things that can go on here. Poverty of speech. They'll just be really brief, sort of yes, no answer type responses to things. Poverty of content of speech is where they're like really vague and abstract. It's hard to follow what they're saying. Pressured speech. They talk really fast and it feels like they just have to get everything out, and you can almost feel this pressure behind them talking. Distractible speech, they'll jump from topic to topic, again, sort of hard to follow the thread of what they're doing. Tangentiality, just be totally off point, off in another direction. Derailment or loose associations, just completely. Where did that come from? Where did that come from? Sometimes they'll have what's called word salad, where they will just say words, and like I've never witnessed this, but I had a friend who did, and she said like this person also had what are called neologisms, where they have like made up words they say. And she said if you tuned out the actual words and just listened to like the prosody, how they were talking, it sounded like they were saying sentences. But then if you listen to it, it's just like the same 3 made up words over and over. Very strange, she said. Sometimes they have errors with logic. Clanging is where they rhyme things. Neologisms, I just mentioned, the new words. They'll come up with unconventional or idiosyncratic ways to use words, those word approximations. Indirect speech, sometimes over-inclusive. And then loss of goal, they can't maintain the topic of what they're talking about. Perseveration is they just repeat things over and over and over and over. Echolalia is where they actually repeat what the person they're talking to says, kind of like a parrot. You can also have echopraxia, where they repeat your gestures. Thought blocking is like they are talking and all of a sudden it's like they can't talk anymore. It's like something stopped them from talking. They may have like very stilted, outdated, odd speech. Always referring stuff back to themselves. They can mispronounce words and substitute words that don't make sense. Alrighty, we're going to get into dissociative disorders, and those are their own thing and take a hot minute. So let's plan on covering those next week. And then I don't think there's a ton more to the PowerPoint. Let me take a quick look. yeah, there's only, well, there's a decent number of slides, but we're through a good part of it. So let me stop share and I'll end this so that the recording will